which is just south of Santa Monica, which is south of Venice. So we're
Yeah.
a ways down the coast.
Yeah. My daughter lives in Costa Mesa. I was just there
Yeah.
last weekend, and they're okay there.
Yeah. That Costa Mesa is way down there.
Yeah. But it seemed weird because just like 30 miles north, people are having
Yeah.
horrible, horrible fires.
Yeah.
I don't think uh anybody has a situation where they don't know somebody who's lost their home.
Yep.
Yeah, very unfortunate. All right, I have already started streaming this live to YouTube. I have the recording going. Nancy, if you wouldn't mind, also if you could record it on your computer, I'm just gonna make sure that you can record on your device.
Where's
I don't
Sharon?
see
Yeah, I don't know.
Let's see. I'm sorry. I had to admit her.
Oh, well, please do.
Yep.
It's not
Sorry, too many
fascinating.
tasks, too many tasks. But all of the panelists are
Well,
here.
there she is. We thought you were bombing out.
No,
We thought Michael was keeping you out.
no. I had like 5 different things on my mind. Sorry. Okay.
Hi, Sharon. You're muted.
Now I'm not muted.
Now you're not
Thanks for that heads up.
Yeah, all right.
Very good.
I got my fidget spinner.
Oh,
I have to tell you, I did 2 lectures for the Arizona Diamondbacks, and you see my background is the Maroon Bells. Well, they ended up sending me a 36 by 23 picture of the Maroon Bells. I could hardly believe. I wondered how in the world he knew I liked him so much. And then I realized because he saw it on my Zoom background.
oh
So now
my
I have something
goodness.
to cover up the mirror in my front room.
Great.
Chris,
All
I
right.
cleaned up my desk just for you.
I noticed.
You did notice.
I did notice what?
My desk is clean. The
Oh, yes. Oh my
the
gosh.
earthquake damage.
Yeah,
Stop
exactly.
working or something?
I'm
Yeah.
going to let everybody into the room now. So you'll be seeing lots of familiar faces, and lots of new faces, hopefully. Okay.
Well, I don't think we'll be able to see them all at once.
No,
No.
no.
Oh, Howard's on.
Very good. Oh, hi, Susie. Oh my gosh, it's so good to see all these people. Wonderful.
Oh,
And
Steve.
we have a dog watching the meeting also. How nice. I love it. Oh, hi, Patty. Leroy, nice to see you. Hey, Marcy's here. Awesome. Look at all our friends. Kara. Hi, Kara. Okay. And Rita, thank you so much for spreading the word. I really appreciate your help. Uh, that was everybody, in fact. I tried to email all PTs that I
What?
know of. So
Rita, you don't have enough to do.
I was making her work extra. All righty. Well, it is time, so I am going to get started, and hopefully it's still live streaming on YouTube. Yeah, looking good. Um, bear with me as I do some technical things here. Okay. Here we go. Good evening, good afternoon, and also good morning to all of you in the Zoom room. My name is Maiko Morotani. I am a PT in Los Angeles, originally from Osaka, Japan. I am a passionate clinician and educator and president of Nexus Motion and Learn Movement System. Welcome, everybody. Thank you to, oh my gosh, so many of you who registered for this event. We have almost 1,500 people registered for this event. So I've increased the Zoom meeting capacity to 1,000 people so that we can still see each other's faces and reactions. But I think we're doing all right so far. But for those of you having trouble joining the Zoom meeting, I'm also streaming this live on the Nexus Motion YouTube channel. We have some polls or questions prepared for you this evening, so everyone in the Zoom room can interact with our fabulous panelists. Likely due to the high number of attendees that we have this evening, we may not be able to take individual questions, but feel free to type your thoughts and comments in the Zoom chat at any time that you wish, or on the YouTube comment section. Those are all welcome. The recording will be available for everybody to watch on YouTube after the event. And to minimize distractions, please keep your microphone muted at all times. We appreciate that. If you have technical difficulty, send me a message and I will do my best to help you out, though my primary role tonight is to moderate tonight's incredible discussion. Right now, I want to know like where everybody is joining us from. So if you wouldn't mind, drop in the chat like what city, state, or country you are watching this from. I believe we have physios from all over the United States and quite the international audience too. So let's light up the chat here. Now, first of all, I want to thank my friend Carrie Hall, who we were actually having a conversation last year about pushing the profession forward in the best ways that we can. And I thought about what stirs the most questions and buzz, and that was tonight's question, in fact. When I've had the opportunities to present talks at PT conferences, I see the most reactions to this question: should the title physical therapist need to change? And let's see, I am going to stop the sharing. All right, let's go. So this question, should the title physical therapist need to change? You know, it creates a lot of buzz, right? And whenever I need help relevant to the physical therapy profession, who do I call? No, not the Ghostbusters. I call my friend Dr. Shirley Sahrmann, and it is because of her today we have the dream team come together for you, and please thank them for volunteering their time. Now, if I say the first speaker needs no introduction, she will totally cut me off, so I'll keep it brief. So she has plenty of time for her PowerPoint slides, which, you know, without her PowerPoint, she has a hard time talking. All right, so Dr.
With my
Shirley
friends.
Sahrmann. Dr. Shirley Sahrmann is Professor Emerita of Physical Therapy at Washington University in St. Louis. Among her numerous awards from the APTA is the Mary McMillan Award, which is the highest honor from the association. She received her Bachelor's of Science in Physical Therapy, Master's and PhD in Neurobiology, all from Washington University in St. Louis. Her unwavering passion and curiosity in understanding the way people move and how that relates to their symptoms have helped countless patients, inspired many students, have taught thousands of clinicians and educators, and guided many researchers. She will open today's webinar by answering this question: physical therapist, does our professional or practitioner's title need to change? The floor is all yours, Shirley, and you can share your slide. Thank you. Oops, sorry, I just muted you. I didn't mean to do that. Sorry, Shirley. Let's try
It's
to
all right.
mute.
It's probably a good idea. Okay, So I'll run on with this because I'm old enough and et cetera. I'm just not holding back. I'm telling you away. I want to get my points in. So I think that it's not just a matter of the practitioner's title, but the emphasis and focus of practice. So the current situation, as everyone knows, is it's clinical doctoral education. But the question's not been out there a whole lot. Why was that degree raised? So we have a professional legal label that says DPT because of our education, but the prevailing title is therapist. And the big issue is, how does being a doctor differ from being a therapist? Well, that's never really been specified. PTs and I was behind this move, and so I feel very guilty because PTs are not recognized as doctors by other health professionals or the public. And the issue is why. And I think that's because we're still therapists and because there's still the same focus of practice providing treatment. And providing a prevailing focus of practice like this is really not consistent with being a doctor. So why was the education raised to the clinical doctoral degree in the first place? Well, of course, as everyone knows, there's been a progressive increase in the responsibility of the physical therapist. Back in the day, we used to get very specific treatments. There were treatment pads, and the doctor would check off what you were supposed to do. And gradually, as the doctor kind of realized we might know a little more than he did about some things, that began to change. And so we were just referred patients. But we still needed that referral from the doctor and seemingly his diagnosis or her diagnosis. And then in about the 1980s, the profession started action towards direct access. And I think what's a bit sad is 45 years later, and it's still only a limited amount of practice. And that's because the MD, we started this doctoral degree because the MD would not see the patient first, and therapists would need to recognize conditions to be referred. That was the reason. Not for what we had a change in our body of knowledge or the focus of practice, but because we had to recognize conditions that didn't belong to us. And the current focus of education does emphasize being therapists, not doctors. Even the accreditation documents emphasize treatment methods. And I have a problem because APTA documents say we're movement experts, but there's no criteria. It's a claim without criteria. A requirement for graduation is to be a diagnostician, but there's no accepted list or manual of the diagnoses that are to be made. No clarification of what the content is. And I'll never forget the House of Delegates in 1984 because they said we need to make a diagnosis. And when somebody said, well, we better get a group together to decide what those are, and they said, no, let's just let it be settled in court. I almost passed out, but that was the end of that session. So we have another claim without criteria. So I found this paper by Jihandi and Matra that said, what are PTs diagnosing? And the medical diagnosis, they state, is important for defining the cause and prognostication. The physical therapy diagnosis, which is a term I hate and totally inappropriate, identifies the limitations of function and the quality of life within a given context of the individual. That's like the ICF, and that's supposed to guide what we're going to do. There are three problems with that. The PT diagnosis is not an acceptable term. It limits it to physical therapy and does not refer to a body system. The ICF starts with a health condition, a disorder or disease. As most of us know, those diagnoses do not direct physical therapy. I was pretty good at knowing when somebody had a hemiplegia, I could recognize they were half paralyzed. That didn't tell me how to treat them. The limitation should be changing as the individual's condition changes. So we need to know how to change that condition. It does not take a doctor to identify functional problems. So looking on the web at what is physical therapy related to the ICF, it said this: if you have a patient with a knee injury, and maybe Chris can help us with this, they would have impaired knee function, body structure and function. They'd have limitations in activity, say, oh, can't walk and have trouble with stair climbing, restrictions in life situations, environmental factors, personal factors. So we're supposed to look at the whole picture. But the focus should be on how do you restore the knee function, because all of those other things are going to change. So to me, they're not an adequate diagnosis. Now, it's not like I don't think they're important, because Linda Van Dillen's paper showed that in chronic low back pain, changing the way people did their everyday activities was more effective than stretching and strengthening exercises. So it's not that they're important, but they shouldn't be the focus of a diagnosis. You should recognize them, but the focus of the diagnosis has to be what's going on with that knee. So doctors should address the knee, as I'm saying, by a classification of the prevailing type of movement system dysfunction. That's the guide to a treatment strategy. And I this is so obvious, but I'm going to just say it's movement causes or exacerbates pathology. We have this really important system to take care of. And there's alterations in the movement system. And these conditions are chronic. They start early and keep growing over time and finally result in some kind of identified acute problem. And I think it's a lot like hypertension. Slowly, your blood pressure is going up. Finally, you have a CVA. Well, I don't think we should be waiting for the CVA. So, and then I think it's good to think about subdivisions of the movement system. And these should be the basis of a diagnosis. Pathokinesiology, which is now you have movement dysfunction because there's a pathology in a component system, like the nervous system. And then you have movement problems because of that, or even the musculoskeletal disease entities, cardiopulmonary. On the other hand, you have kinesiopathologic, which is movement causing or exacerbating pathology. And the big deal to me is you change the movement to treat the impairments and symptoms rather than try to treat the symptoms to enable movement. So this is now these systems are producing the pathology. So it's the opposite flow. And Patty Sheets in 2007 published a very nice paper to illustrate what I'm talking about. And these would be pathokinesiologic movement system diagnosis. So she wrote about 3 patients that all had a cerebral vascular accident. But one patient, based on the examination that she's worked out, had a force production deficit. Another one had a fractionated movement deficit and then a perceptual deficit. These would provide guides as to what the intervention would be which is not the situation as it is now. So the title change should be associated with a practice change from therapists who provide treatment that's characterized by unwarranted variability. It's short-term management. You get a limited number of treatments, never to be seen again, to something like an ologist, because they have expertise in a physiological body system who make diagnosis of that system's dysfunction, and that would help reduce variability and increase effectiveness of the treatment program. And you'd have ongoing management, see them on periodic examinations, or they'd know to come back to you. And just for the record too, about this change in practitioner title, speech therapists are speech and language pathologists, and they didn't even change their degree level. So the prevailing identity and practice to be recognized as doctors is that right now we're known for what we do and not what we know. That's been a number of APTA documents. But what should we know? What is expected from doctors? And I thought we were kind of on our way when in 2013, the movement system was identified as the identity. And that there would be knowledges of and diagnosis of these system dysfunctions. And then recognizing that movement science is really the underlying basic science for this. So what does not change? And just to be clear, the name of the profession does not change. We're still providing physical therapy. The only change is in the title of the practitioner. I might have some suggestions, but I think it should be an ologist and not a therapist. And examples of movement system diagnosis, the kinesiopathologic ones, we should have a manual of these movement-related causes are ones that exacerbate pathology, the provocative movement. And these are primarily impaired osteokinematic or arthrokinematic movement and contributing factors. And that would provide treatment recommendations. The pathokinesiologic ones are like the examples I just showed you from Patty's paper. And I thought I'd give you some examples of what I'm talking about for kinesiopathologic diagnosis. This was a woman that came in who had femoral posterior glide. We would call it femoral posterior glide with medial rotation. This is not her, but this is what she could do. And she taught yoga, so she did this a lot. And then she'd rotate medially and she'd rotate laterally. And if you want to posteriorly dislocate your hip, this is a very good way to do it. And she was working on that. This is the way she liked to sit because, again, all of the posterior structures were so stretched out. It got so painful she really couldn't sit, tried not to sit, And if she did, she had to sit like this. And then just to make another example, and I put this picture up from Donald Newman's kinesiology book as a reminder that when you flex your hip, you ought to be able to run an axle through it for flexion and extension through the head of the femur. And in this young woman, her left non-painful hip, when I flex it, my thumb is like a parallel axle, and I passively flex her hip. You can see that my thumb and hand are staying absolutely still as I flex her hip. The right painful hip is a different story. So if you watch here, my thumb again is at the inguinal crease, my hand is around the femur, and you can see both my hand and thumb are moving. And I'll put my finger up because she's now very close to the ASIS because of all of this excessive hip motion, both an anterior glide and hip medial rotation. And then just to confirm that this is indeed a provocative, faulty movement, I'll put my thumb in the inguinal crease, hold it there, so that when I flex the hip, it matches the one on the other side. And then I can flex it like that as well. But then watch what happens when she takes hold of it, and you'll see all of this excessive motion. And there it goes. So again, this is extreme, and that's why that hip was painful. And with the knee, this young woman was an Olympic level marathonist. She had posterior knee pain. She was getting 6 ultrasound treatments to her posterior knee, but she still couldn't run. This was the natural way she did it. Just showing her how to do this, not only during standing, during walking and running. And then she was able to complete in the Panhellenic Games, came in 3rd. And I never had to see her again. She sent postcards, called me and said, I know if my knee hurts, I just need to tighten my buttock more. So it's addressing these faults. And this young woman, when she would go up a step and she allowed the femur to go medial of the knee, which is partly because her foot is so stiff, then if you correct it, she doesn't have pain if she goes up the right way. And then just one final example from the upper extremity. Watch as this young woman immediately takes hold of her shoulder. So this is scapular anterior tilt and internal rotation. That's the fault of the scapula, this excessive motion. Now this is about 5 minutes later, changing the moment arm, teaching her to control her scapula and let go in the glenohumeral joint. So we can get an immediate correction in these movement patterns because this is a matter of neuromuscular activation. And I think people need to think about this question. Why do normally innervated muscles become weak? They do because of this neuromuscular activation problem. So the idea is to look at that, not just strengthen them. So how does a change in the title help? The idea would be to convey to both those inside and outside the profession that practice is based on knowledge of and expertise in a physiological system, the movement system, like a doctor, rather than on treatment skills like a therapist, and convey that movement is a cause of pathology, and it's a cause of pathology and can be effectively classified and modified so that recognizing, maintaining, and restoring optimal movement is complex. It's more than strength and range of motion, and that we should have ongoing responsibility just like the physician does. And we need to emphasize the development of movement-related diagnosis. That's what's going to help guide treatment and make it more effective and less unwarranted in its variability. Suggestions for the title, I really believe that it isn't the big deal, is that an ologist would be consistent with other system specialists, but again, that's not the big deal to me. The big deal is changing it from therapist. Okay, I thank you for that fast run through. That's the idea, and I look forward to comments and questions from my colleagues and from everybody else out there. Thank you.
Awesome. Thank you so much. I'm going to now introduce the next speaker. Let's see here. Sorry, just playing with the spotlight here.
Got rid of me.
All right, there's everybody. And here we go. And so thank you for that presentation, Shirley. And then next up, sharing his thoughts and response to Shirley's suggestions is Dr. Christopher Powers. He is a professor and associate chair of the Department of Biokinesiology and Physical Therapy at the University of Southern California, co-director of the Musculoskeletal Biomechanics Laboratory at USC, and founder/owner of MPI, Movement Performance Institute in Los Angeles. Dr. Powers' research in the biomechanical causes of the lower extremity injuries have been well read and cited very often. He's a past president of California Physical Therapy Association, and with numerous awards and honors from CPTA, APTA, and USC, he continues to lead us with his passion of biomechanics and movement. So thank you, Chris, for being here today. And I am going to replace the spotlight to you.
Oh, thank you. Thank you. Welcome, everybody. Good evening. I have the pleasure to respond to Shirley's presentation. And I'm going to keep my comments short, but I do have a few thoughts I want to share with you. And I also want to point out that Shirley did mention that patient with knee pain. You really had her squeeze her glutes, right? Is that what you said, Shirley?
Well, just to get to the deep rotators.
Oh, got it. Okay. Anyways, I really want to start off by saying, I agree 100% with Shirley on a couple points, and I'm, as many of you guys know, I'm 100% on board with the premise that physical therapists should be recognized for their expertise in movement. I mean, couldn't agree more with Shirley on that point. And I kind of like the idea of the ologist versus the therapist. I really like what the speech therapist did, moving to speech pathologist. And maybe at some point we can get to that point. But to be perfectly honest with you, I think changing our professional title at this point in time may be a bit premature. And I based my opinion on basically two questions I asked myself, and I think before we even consider a change, we have to consider these 2 points. First of all, is the profession fully on board with movement as being our professional identity? I know everyone here is a movement junkie. But I'm not 100% convinced that the profession in large is 100% on board. The movement system, which we were all part of, Shirley, back in 2013, is kind of died on the vine. And to me, that says something. That says that the profession, we haven't embraced that concept yet universally in the profession. And the other big point is, are we really training our students to really be movement experts? Are we movement experts? We can call ourselves movement experts when we're really not movement experts is highly problematic. And we can question whether or not we're even considered to be diagnosticians for that matter. So I think these are really important points. And in changing our professional title to something that we're currently not doing or highly trained to do would be problematic. And I think we have some work to do before we can, consider this. In general, I like the idea, but are we ready for it? I think that is my big concern. I want to, I think we first need to build a professional culture around movement that currently does not exist. And I'm gonna use an example here. There's a segment of our profession that identify themselves as manual therapists, right? I mean, there's a segment of physical therapists that consider themselves, I'm a manual therapist. And manual therapy is obviously a very important part of our professional, or it's a recognized specialty in our profession. But manual therapy did not just start overnight. It evolved, and when you look back at the history of this, and I'm going to draw a parallel here in terms of what I think we should be doing with respect to movement, because back in the 80s when I was in PT school, manual therapy wasn't a thing. It wasn't taught. It wasn't even recognized back then. But today, manual therapy is fully recognized as a specialty. There are professional organizations that certify manual therapists, AOMT, IFOMT, etc. Manual therapy is taught in the PT curriculums. It's part of CAPTE requirements. And, we've gone from nothing to being an integral part of our practice. And maybe we should, take a page from that playbook in terms of movement. Because right now, I question whether or not, we are really teaching our students what they need to know to do what Shirley's proposing that we do. And now I know at WashU and USC, we are the two movement capitals, I think, in terms of educational programs. But I think right now, the skills of the movement expert are largely being taught as post-professional education. And Shirley, you've built a whole post-professional educational program around movement. But right now, if a physical therapist wants to become a movement expert, they go to see Shirley Sahrmann. And why do they need to see Shirley Sahrmann? Because they're not getting it in their professional education program. And I think this is a big problem. And if we're not teaching our students how to diagnose or how to, look at movements, what's the point of changing our professional title? So, I think a couple of things that we need to do. We need to develop and promote core competencies around diagnosing and treating movement impairments. Shirley, you obviously have been a leader in that area. And maybe right now, maybe we should develop, an organization or a certification process similar to what the manual therapists have done in terms of, creating movement therapists, maybe not taking the ologist step yet, but maybe creating a cohort of, or a certification around movement therapists, that people who are recognized within our profession as having those core competencies, similar to what it has to happen to become a manual therapist, to be certified by AOMT or IFOMT. So maybe movement therapists could be a compromise at this point before moving to ologists. But I would argue that, students out of school right now are not experts, and maybe wouldn't be viewed as experts by our medical colleagues. So to kind of summarize here, I'm 100% on board with movement as our professional identity. I mean, I think everyone here knows that. And but I think it's my opinion at this point in time that changing our professional title may be a bit premature. I think we have a lot of work to do to promote movement and to really make sure we are truly experts and really practicing what our name implies. And I look forward to hearing what the other panelists think on this problem. Thanks.
Thank you so much, Chris. We have some more ideas bubbling up. And yeah, as you all are listening to our panelists' thoughts and ideas, feel free to use the chat function and put in your ideas as well. Now, panelists, I do have questions for the audience. So if you feel like at any time you would want to get some feedback from the audience here, let me know which question you would like me to post. All right. Next, I am delighted to introduce Dr. Paula Ludewig. She is the director of the Division of Physical Therapy at University of Minnesota. She is the co-director of the Minnesota Rehabilitation Biomechanics Lab and often collaborates in her research with the University of Minnesota Orthopedic Department. Now, while she works with the future PTs at her school, she is well known for her research in shoulder biomechanics, particularly in the prevention and rehabilitation of shoulder dysfunction. In 2022, she shared with me in an interview her thoughts on how AI could be a big influence to the future of physical therapy education. So, needless to say, she has many key insights to share with us as an important leader in physical therapy. Thank you for your time. And the mic is all yours, Paula. I'm going to switch the spotlight to you.
Thank you very much for the opportunity to share some thoughts and perspective here. I also fully agree, as a profession, we're underutilized in, I would say, both quantity and quality of what we do. And there are just huge opportunities, I think, for the profession and our contributions to value-based care. But to fully realize those opportunities, we need to be recognized by the health system and the public for all that we have to offer. And I think we have the capability to improve access to care, address physician shortages, serve as primary care providers, primarily in musculoskeletal care, but other areas as well. We can reduce costs, much like has been done in the military. But there obviously are barriers that have prevented us from getting there so far. And so changing the name from therapist could be part of a multifaceted plan. Retaining physical therapy as the degree is what I understand Shirley's advocating for, but changing just the professional title. I think, what would the name be? The movementologist, I would say, is really already taken, because that's a kinesiologist. And so I would caution being a little bit careful about that. A kinesiologist on a quick web search is defined as a movement science practitioner. We're sort of a movement health practitioner, I think. And kinesiotherapists exist in the VA system. And there's an associated degree program and all of those sorts of things. So I think we have to be a little bit careful with that language. So I personally don't have a great alternative for the name change. I am in no way opposed to it, but nothing jumps out at me as this is the perfect name that we would change to. I think the bigger factor than the name is our defined and practiced expertise. So again, the second part of what Shirley put in the title, to change the emphasis of practice, I think we absolutely need to do. And we've been trying to do this for a while, but there remains extremely high variability in practice. We say we diagnose, but what is our specific diagnostic domain? What is the system we diagnose in? In Minnesota, for instance, a physical therapist cannot make a medical diagnosis. That is in the Practice Act. And I want to read for you an excerpt from a letter that was from the Minnesota Podiatric Medicine Association in 2022 in response to proposed legislation removing some barriers to direct access in Minnesota. So we have direct access, but it's constrained in two ways. You have to have a year's worth of practice experience, and after 90 days of direct access, a person would need to go back to a physician. So this is from this letter from the podiatrist arguing that we should not be able to change from that limited practice. Physical therapy evaluation is not a medical diagnosis. Physical therapy curriculum is heavily focused on rehabilitation and therapies to assist in rehabilitation of a functional deficit. Much of the physical therapy education and training is focused on being a treatment modality, which reinforces some of Shirley's points here. Without extensive education and training in the science and art of medical diagnosis, which physical therapists do not have, including the ordering and interpreting appropriate tests, the physical therapy evaluation is only an evaluation and assessment to prepare a treatment plan for the patient to follow in the delivery of services only within the scope of physical therapy. Physical therapists do not have educational standards, training, residencies, fellowships comparable to medical doctors, podiatric physicians, dentists, chiropractors, and advanced practice nurses to make medical diagnoses. So they're saying all of those other professions have what it takes, but physical therapists do not. They go on to talk about that as in 2021, 67% of PTs in Minnesota had a doctorate degree. That means that a lot of others don't have that doctorate degree. And so that was an area of concern as well. They're saying the doctorate degree does not substantially increase the physical therapist's ability to properly make medical diagnosis for the safety of their patients. The burden is upon the physical therapist to prove that there's been a substantial change in their education and training that permits them to make medical diagnosis, justifying direct access. Burden of proof has not been met. Then they go on to talk again about these other professions, particularly podiatry, which is apparently 4 years of school and 3 years of residency, and how that prepares them. And again, emphasizing that physical therapists don't have that extensive level, particularly the residency and fellowship education. So the issues being raised in this letter are educational standards. And it goes back to some of the points Shirley made, some of the points that Chris made. And I don't think a name change would really impact this discussion a whole lot in that regard, because it doesn't change the educational standard explicitly. But nurse practitioners and physician assistants are paid more relative to their identity as diagnosticians, even though their scope of training certainly does not exceed that of physical therapists. In fact, here at Minnesota, our faculty are teaching MSK to the nurse practitioner program, which is, I don't think, unusual. So a few summary points. We definitely need to define, publish, and test diagnostic classification frameworks. That's going to take time. In the meantime, CAPT criteria definitely need more specificity and consistency in terms of what defines movement and diagnostic criteria in DPT education. I echo Chris's comment. I do think we should consider additional certification, because I think it will help drive things forward faster. For whatever reasons, I agree that it seems like there was a lot of enthusiasm, there was a lot of energy around the movement system and practice, and everybody embraced it, but then nothing really happened to make it clear, and certainly in the realm of diagnostic criteria particularly. Also, residency and fellowship training is really needed, I think, but students aren't pursuing it because of the cost of DPT education and the debt that they come out with. So programs where we can reduce the undergraduate education, 3 years, so 3-year undergrad, 3-year DPT plus 1 year minimum residency. I think we need to, and I know there's lots of discussion around these things, and there's lots of barriers to make them happen. The other thing is working with health insurers directly. Again, there's literature out there showing what has happened in the military model, and we need to use those things and hopefully get into the systems where the systems are making the decision, and not just the physicians all the time about what aspect of care we can provide. Dentists also are more open, I think, to physical therapists in primary care types of roles. And so that's another line of things that I think we need to continue to pursue. So in the end, I'd say I don't have any opposition to the name change as long as the name is reasonably appropriate. But I think the more critical pieces are resolving our diagnostic dilemmas, enhancing our education standards, and working with insurers and health systems to engage PTs in primary care practice.
Excellent. Thank you so much, Paula, for your insights, and I'm just thinking so much about this isn't just clinical practice. This is the whole PT, from education to what's happening out in the clinics, and obviously will be relevant to all the researchers there as well. Now, our final panelist, who I am so excited to bring on, is Dr. Sharon Dunn. If you are in the United States, you all know of her because she served as president of the American Physical Therapy Association for 2 terms, from 2015 until recently 2021. She is the Vice Chancellor for Academic Administration, Dean for the School of Allied Health Professions, and a Professor of Physical Therapy at Louisiana State University, or LSU Health Shreveport. She's a board-certified orthopedic clinical specialist and has research publications in topics such as osteoarthritis, mechanical loading on healing tissues, and its influence on genetic expression. She is a servant leader and here to share with us her thoughts. Thank you so much, Sharon, and let me put you on the spotlight.
Thank you. And I looked over the list of attendees, and it's like a who's who of physical therapy. So I really appreciate this opportunity to share my opinion. 3 months out from my retirement as president of APTA, Shirley called me and said, okay, you've got 3 months to do this. You're going to change the name of the profession to movementologist. And I had a big laugh, and I said, you know, that sounds easy, Shirley. Let's do it right here, right now. But at my own peril, I'm going to disagree with Shirley about our name. I agree on everything else that's been said by Shirley and the other panelists. I don't think we need to change our name. Rather, I believe we need to more responsibly and more assuredly step into the role that already exists for us as doctors of physical therapy. 2 keywords, responsibly and assuredly. Responsibly means that we take the accountability, responsibility, and obligation inherent in fully managing our patients and the public's movement impairments, managing their risks to optimum physical function and performance, and our responsibility in enhancing our patients' ability to participate in activities and obligations that add to their quality of life. When I say assuredly, I mean that we need to quit conceding our role to other disciplines and playing small in circles of health systems and other health providers. We need to have confidence in our scope and role and quit apologizing for who we are, what we know, and our value to patients, health systems, and society. Until we fully own and practice by the standards and scope that we currently have, the legal and regulatory right to practice, a simple name change will not bring us to that holy grail. And so those who came before us paved the way and removed barriers for the practice opportunities that we enjoy today. We talked a couple of times already, other panel members, all 3 actually mentioned CAPTE and the CAPTE standards. We obtained our ability to be self-directed in our academic standards when we envisioned CAPTE. So now our profession charts our own educational course. So it's up to us as the profession to move CAPTE towards the standards that would, in our vision, create the type of practitioner that would be what we imagine a great clinical practitioner of movement science would be. We also have licensure in every jurisdiction, state boards that are governing our practice that are directed by physical therapists. We have term and title protection across the country. We have direct access in every jurisdiction at some level. Paula talked about the legislative battles that we have, and that other practitioners go to those committee hearings and try to berate who we are as physical therapists. And I called nonsense on the podiatrist that wrote all that stuff to your legislative committee, because that was just a passionate plea to reduce your efforts there in Minnesota. In the year 2000, the House passed Vision 2020, where it was an audacious goal at that time, and that was only 25 years ago. It was an audacious goal that we would become doctors of physical therapy with direct access, using evidence to inform our practice, with professionalism for which we would then become the practitioners of choice. So 25 years ago, but then CAPTE quit accrediting non-DPT programs in 2015, 5 years ahead of that goal. So the profession somehow moved quickly after Vision 2020, 25 years ago, on our educational credential. All states at this point have a decent form of direct access, and we have more research on which to base our clinical decisions than ever before. I would argue that what we continue to lack today from that Vision 2020 is the widespread professionalism that would facilitate us becoming the practitioners of choice for movement, prevention, exercise, and health. It's not a title that will make that happen, though. It's our collective and consistent behaviors. Our behaviors are still quite focused on ourselves rather than that which our current vision calls us to focus on, and that's the societal need for our profession. In 2013, we transitioned with this new iteration of our vision from an insular, inward-focused one, which was necessary to mature us, to what we currently have potential to become. But the importance of the new vision to, number one, our societal obligations. So the vision statement starts out with transform society. To number two, use our profession's specific body of knowledge, which was by optimizing movement. To number three, with the most critical outcome of our practice, that's to improve the human experience. Transforming society by optimizing movement to improve the human experience. The House adopted this vision in 2013, 12 years ago. Then 6 years ago, thanks to Chris Powers in the California chapter and a lot of work in the House adopted guiding principles that implored us to promote the movement system as the foundation for optimizing movement and to recognize and validate the movement system as essential. And we're still arguing over whether or not we need to develop and defend our role in optimizing movement. And in Shirley's videos, I think everybody on the Zoom call today could see the obvious movement impairments and identify a course of action to treat them. But has our accreditation standard come up to critically preparing our current graduates in that? I don't think so. Are we consistently practicing at that level across the country? I don't think so. Again, I believe this goes back to our professionalism and our lack of collective and consistent behaviors that would assure our rightful place and unique knowledge about human movement. So, and I've seen a lot of the questions on the chat. So what do we do about it? You know, we can cry and moan about it. What do we do? So one, I would say we elevate our expectations of ourselves and our colleagues in a consistent standard of practice. Two, we hold ourselves accountable to the societal expectations of our profession. Three, we stop tolerating a productivity standard related to an outdated and absurd payment system and demand the highest standard of ourselves and demand a payment system aligned to that standard. So a name change won't do all that, but perhaps a renewed passion for who we are, a renewed passion about our unique knowledge and skill set, and a renewed passion for the value we bring our patients and the societal need for us and our profession just might. That's where I think we need to focus our time and energy on. Accreditation standards, assuring consistent practice across the country, and meeting society's need for who we are. So sorry, Shirley, for disagreeing about the name change, but I did see interventional movement pathologist come across the chat room. That's interesting. That's an interesting possibility. So I'm not opposed to it. I just think, as Chris does, that we need to get our house in order before we take that next step.
All right, thank you so much, Sharon. And wow, who is getting inspired here in the Zoom room? It's we've got a lot of work to do. But right now, I guess since we are actually ahead of schedule, can you believe it, guys? Everybody did on time. Um, Panelists, what do you think about me posting some of the questions for the audience so that maybe we can capture what folks are thinking, and we can take it from there, and then we can open it up for all four panelists discussion. How's that sound?
Fine.
Awesome. Okay, so what I have prepared for you are some questions. And I guess we could first start out with, um, let's see, what are your thoughts? Do you think we should change the name of the practitioner's title from physical therapist to something else after you've heard all four presenters' thoughts and opinions? And yeah, just kind of click yes or no. Simple thing will take 10 more seconds or so, and then I will share the data with you all. And sorry for the YouTube folks, you will not be able to interact here in the poll. All right, I'm going to go ahead and end the poll and then share the results. All
Wow.
right. Good. So 39% says yes, and 61% says no to the question about changing the title. Um, Next up, well, for some of you who said yes, I guess what would be the what would be the appropriate new practitioner's title? And this one is I think you should be able to type in your ideas. And then I guess we may see a long list, or for those who says no, then you don't need to type in anything here. We also see some ideas in the chat here. Uh, Interventional movement pathologist, musculoskeletal movement pathologist, interventional musculoskeletal pathologist. And to that, Rob Landell, thank you for participating, that it was a little bit limited to the musculoskeletal physios. So that was a good point. Okay, I'm going to end uh, the poll in about 5 seconds. Still people typing. This one, I'm going to give you a little bit more time. Good. Okay.
I'm going to make one comment too, because I
Yep.
saw others make it, like Janet Biesner, and uh, which is, if you do pathologist, in some ways you're concentrating on what's bad. And I think that even those visions talk about prevention. And I think that keeping the mindset that we could prevent things and not just find a pathology is really something to think about.
I see. So we have someone suggested following after French title, kinesiotherapeutic. Sorry, I don't speak French, so kinesiopathologist. We should no longer shorten it to PT. This gets confused with personal trainers. Physio, moveologist, kinesiopathologist, movement specialist, physiotherapist, movement interventionist, pathokinesiologist, biokinesiologist, somethingologist, physiotherapist, doctor of physical therapy, physical therapist, movement doctor. Okay. All right. Thank you for sharing those ideas. And we're going to go to the next question here. Let's see. Not personally, but as a profession, are PTs experts in the evaluation and treatment of movement dysfunction? So let me just launch that question. This is just a simple yes or no question. Do you think as a profession, are PTs experts in the evaluation and treatment of movement dysfunction? Good, about 5 more seconds or so, and I'll bring on all the rest of the panelists here up on the screen. Okay, looks like I think most everybody have answered. And 58% says yes, and 43% says no, we are not movement experts.
Yeah.
Hmm.
So is this, I'd be curious to hear why. So is it because we are not supposed to be movement experts, or we just don't have the necessary training to be a movement expert? So to me,
Yeah.
this is very telling, I mean, and this is the movement group, I mean, I think everyone here, we're speaking to the choir, so to speak, but the fact that the choir, 43%, do not think that we are there yet kind of reinforces the point I was making earlier that, how can we change our name to movologist if we're not truly experts, or
I think it's very hard for people to know what a movement expert is.
True, that's a good point. But I would, I'd be interested in knowing, apart from this group here, if everyone that goes to CSM answered this question, I'd be really interested to see if the percentages changed at all, if they flip, but how would a manual therapist view themselves, I wonder? Would they, someone that recognize themselves as a manual therapist, how would they answer this question?
Yeah, and sorry, I don't have that question prep. So if
Oh,
folks,
no, I'm not saying don't do it, but I'm just throwing out a question.
yeah, I think this will lead right into the next thought.
Hold on a minute, hold on.
Mhm.
I think that what needs to be thought about, I would like to go back to the name change bit in for this question. Is it because they think, as Chris has proposed, that it shouldn't happen until, well, I guess the practice is changed, or they don't think practice should change anyway if we're all movement, if the majority of people think we're movement experts. But is it, that's the reason that they want to concentrate on a change, or they just don't like the whole idea that we should change from being therapists? And then one other point, it's like this, even this thing of manual therapy. What does manual therapy say? I treat you. It doesn't say I understand your problem. It just says I have a treatment method. And I think that's what's so unfortunate, because we aren't doing anything that says I understand the problem. It's all about, this is what I'm going to do to you.
Mhm.
I would say to Chris's point, when we did a conference for the annual meeting for the academy, and the title was Manual Therapy and Movement, and we asked the people that were there, if they viewed themselves as movement people, they said yes. So I think manual therapists view themselves as movement experts, and it wasn't a conflict in their minds to say so.
Yeah, I don't think people know what a movement expert is. I think that's the problem.
So I've actually posted this question: should practice emphasis change?
Oh, there we go. That's good.
And 73% says yes,
Oh,
the
good.
PT clinical practice emphasis should change. 27% said no.
Oh, well, that's good. That's hopeful.
And
But
yeah, go ahead, go ahead.
I think by next week, Chris will draw up the guidelines for us.
Yeah, very quick, very quick. Now, next question I have for you all. Should we have an approved list of diagnoses that PTs can choose from? Here is the question. This is also another yes or no question. Should we have an approved list of diagnoses, sorry, not diagnosis, but diagnoses that PTs can choose from?
Yeah, I'm just gonna say too that the point I was trying to make with regard to what the podiatrists are saying is not that we should make medical diagnoses necessarily, but if we're not making medical diagnoses, what diagnoses are we making? Because we don't have defined movement system diagnoses. And so that is exactly the figure it out part, right?
Yep.
And so that's where we've got this gap. And there've been a number of questions in the chat about what CAPT criteria are, and they're very vague. They say that that you have to identify the movement, I think it's system, and movement science, but they don't go through explicitly what that means.
Okay, and here is the result regarding list of diagnoses, and 68% says yes, we should have an approved list, and 32% says no.
Yeah, I think, this whole discussion about diagnosis it's been highly controversial. So, and I think we've had many discussions about this and how to do it. And, how is that diagnosis, is it a movement diagnosis or, the whole pathoanatomical diagnosis, and that's that debate. And I think this discussion of diagnosis, we lost. It seems like it almost somewhat derailed the focus on movement. I think people got so caught up on the diagnosis that, people, I don't know, it may have contributed to derailing the momentum of the movement system. And just a thought.
But it's not a clear thought to me, because if you have a system that you're supposed to be in charge of, how can you be in charge if you don't know what the dysfunctions are of that system? And so you got to have labels that say, I'm figuring out what's wrong with that system.
Yeah, but
think-
I remember the discussion was that the labels are so foreign to other medical practitioners that
They can learn.
they won't know what we're talking about. So
Yes, they do. Yeah, they know about flexion and extent. I'm just going to argue this point with you, because the first person, when my book came out 100 years ago, and I delivered it on horseback, the first person that was the first person that was interested was a physiatrist. And I've spoken to the neurologists, and they do understand about flexion and extension. And it's not real hard. Maybe they don't get a lot of kinesiology, but they can learn. I always look at who knew what FAI was, and still most neurologists do not know what FAI is, and a lot of other people don't know what FAI is, but they could learn. And particularly because movement's such an intrinsic part of our lives and what they see.
I think Chris is right though, Shirley, because we were there in the room when we started having the conversation around movement diagnoses, and I've seen the enemy, and it is us. We couldn't get over ourselves to identify a path forward related to the validation of the movement system, which the House called us to do.
I know.
Support optimizing
15,
movement and then
2015.
validate the movement system. And those conversations got so steeped in process that it wasn't really about what we needed to do, but how we'd go about doing it. And we tripped over ourselves. I appreciate you showed Patty sheets, 3 different scenarios of someone with hemiplegia, and the what a proper movement system diagnosis would look like, because that was, I mean, even for me, an orthopedic therapist, I could figure out what Patty was thinking as a neuro therapist, and the diagnosis guiding the intervention. And so I don't necessarily think communicating this beyond physical therapy is the problem. It's, we need to get out of our own way and validate this as our practice so that we can then incorporate what the standard is in our educational accreditation standards and beyond. And so, yes, that Chris is right. We got derailed when we started trying to create the movement system diagnoses.
We also, I mean, there was considerable backlash on the movement system, period. I mean, not the concept, but the name. You know, a system of systems that doesn't exist. I mean,
But it doesn't
I mean,
exist. What's the immune system?
well, I just look, Shirley,
What's the metabolic system?
you were there, you heard this. I mean, there was a lot of opposition to the term movement system. I mean,
Internal opposition. We can't get out of our own way.
I know, that's what I'm saying. There were hours we spent talking about this, and that's exactly it. We couldn't get out of our own way, and I think the whole concept of movement is kind of died a bit, and we need to bring it back.
I'm not going to be able to sleep tonight hearing that.
Well, you know, Shirley, you know, because this is why we're doing this. I mean,
Yeah.
What are we if we're not movement people? I mean,
Exactly. I think the foundational science is in our entry level curricula, but putting it all together is not.
yes, we
Well, I
get it
think
in pieces. We get it in chunks and pieces, and students never understand how it all fits together and how it really is applied from a practice standpoint. You know, they learn techniques and they learn
right.
what to do.
That's my
but-
whole point. They
Yeah.
learn how to be therapists, providing treatment.
Well, here's the result to the question. Not you personally, but as a profession, do PTs diagnose movement problems and recognize movement interventions? And to that question, 63% of the participants said yes, 37% said no.
I just have such trouble with this. How can you say you're diagnosing something when nobody knows what the label is? And two people could look at that same person and give it different labels. It doesn't say that there's any constancy in what this profession's about.
And the next question we have for you all is, what is the focus of your treatment if you would rank order from most important, which would be number 1, to least important, number 4? I understand that there could be a lot more on this list, but just out of pain, neuroscience education, tissue loading, movement, nutrition. So trying to rank them from most important to least important. I guess Zoom poll questions have evolved, so now we can try to take different types of answers. So I didn't know they had this kind of ranking before. Give you about 5 more seconds to try to rank. Alrighty, and I'm going to end the poll now. And let's see the results. Okay, so number 1 is the light blue, number 2 is dark blue or navy, number 3 is orange, and number 4 is teal. So it looks like movement is ranked number 1, followed by tissue loading,
Oh, it's followed by neuroscience.
followed by pain neuroscience education, and then nutrition. And sorry, folks, I know there could be a lot more on this list. But okay. And then the last question I have for you all, which is, what differentiates us from personal trainers, yoga, Pilates instructors, athletic trainers, or physicians? So in general, like other professions, what makes us unique? And this would be, you can just kind of type out your answers. We've got a couple of response, 4 people typing out. This may just take a little bit of time as it's not like a yes or no question. What differentiates us from other professionals? Okay, and maybe about 10 more seconds or so. Good. And I'm sorry if I cut you off, then you can post it in the chat. Let's see. Oh, good. 67 people answered. 70 people answered. Okay. Now, can you all see the results on the screen?
No.
No. Okay. What about now?
No.
No. Okay. So what I would do, there are lots of people who typed up and they're quite long answers. So I will figure out a way to share what people typed out in maybe the YouTube channel comment or something like that.
I also have another comment unrelated to this, since you're going to be messing, which is, I noticed in the chat, a lot of people said we need the residencies, but do the residencies guarantee that you're going to learn the skills that you're supposed to? I have big worry about that, particularly as larger corporations are owning services and pushing for productivity. I don't know that the standards for treatment are, that there's time for an exam if you knew what you were examining. I mean, to me, that's not having diagnosis, and that's the other question. Be interested. How many people have a systematic exam they do on every patient that comes in with a specific regional complaint?
Shirley, do you think, so obviously making a diagnosis requires doing an evaluation, examination. Do
Yes,
we
it
have
does.
this, do we have the skills to examine movement?
You
I'm,
want
I'm
my
curious. So
honest
you
answer?
can't make a diagnosis unless you can evaluate the patient. So do you think, I mean, you teach this. I mean,
Oh, I do. Yeah. So I think you can.
you teach this all over the world. And the fact that they have to come take a continuing education course to learn this tells me that they don't have that information out of school.
Chris, it's more than that. When I ask people, did you learn a set physical exam when you went to physical therapy school? And the only one they'll say is, a special test,
Yep.
special test. So
So
I said, do you operate or do you prescribe drugs?
so going back to my original comments is, we're far from diagnosis because we haven't even adopted movement as our professional identity, and
Yes, you
2,
did.
we don't have a systematic way to look at movement. And without those two, what use is a diagnosis? And I think we jumped from point A to point Z in our discussions here,
But
not tonight, but 5, 6, 7 years ago,
but you
and
but
we
uh,
derailed the
uh,
train.
but Chris, if you're going to have a systematic exam, you're going to have it to go to some particular point, and you use that systematic exam to get to the diagnosis. So as you said the first time, they're intrinsic, but we can't be teaching systematic exams when they don't know what the endpoint is of that systematic exam.
Well, I guess you can look at it either way, you know. And,
No, I can't. Tell me what's the other way to look at it.
well, yeah, I mean, it's like without having the skill to what, I mean, look, you have amazing skill to look at a patient and figure out what's wrong. Okay, you look at someone and you have magic and you know what's going on. You know, most people will look at the same page, have no idea what's going on. And if
know,
you
that's-
don't know what's going on, how can you come up with a diagnosis? And I think
But-
we can come up with labels, but we don't have a process to get to those labels.
Okay, well, you talk about the medical, what's the medical system? These are the diagnosis people, and then these are the examinations we use to make that diagnosis. They don't just, you know, it's not like, well, we'll just examine something, but we don't know where we're going with it, you know?
Would
Mhm.
you argue that movement analysis, which you do, is a skill?
Well, absolutely.
Yes.
That's what you're supposed to go to school for 4
Yeah.
years.
So if we're not teaching the skill, then people aren't doing it in practice, and that movement
Well,
is
you know,
part of their.
As I tried to say, my big worry is there's no emphasis to teach the skill, that the emphasis on teaching treatment. But who knows what they're treating? Because I really don't believe that the medical physician's diagnosis directs our treatment. Not at
It-
all.
It took me a lot of reps to get good at the skill. And I was not adept at observing movement as a new graduate. It took a lot of reps of watching people move to develop the skill. But that was before we had the technology that we have today, that we're not even incorporating into our clinical training either. And you and Chris Shirley did the debate, Oxford debate, where you talked about technology or not. And Shirley, you have developed the skill through your human observation skills that novice clinicians could probably use technology to identify movement impairments better than taking the time to develop the skill that us old hats have had to do. So I think that is another issue that we need to bring to the forefront. What are the technologies that would help us become movement experts? And there's a lot at our disposal that we're not using.
Yeah,
But I think, Go ahead.
how many physical therapists can do a systematic gait analysis? I mean, think about it. I mean, gait is the primary movement of human beings, right? And that transcends all disciplines, neuro, ortho, cardiopulmonary, whatever. And I don't think most physical therapists can do a systematic gait evaluation and really understand what they're seeing. I mean, I come from, Jacqueline Perry's lab, gait was, beaten into you, but, I think about it from a movement analysis standpoint, there's that has to be at the root of every physical therapy education program. Is like, if you can't systematically evaluate how someone's walking, for example, that's a problem. And I don't think most new grads can do that.
Mhm. Exactly.
And let alone the tests and measures that Shirley talks about, I mean, just.
We do have a lot of that stuff, right? And that's what we need to come to consensus on. And like Chris, you have what I would call diagnostic classification for knee pain, based on movement. And why isn't that being standardized? We have pattern recognition of sets patterns. It doesn't include every possible scenario we're going to see in the clinic, but there are some common ones that we have and that we should be clearly and explicitly defining and saying this should be part of the standards of what everybody should be doing.
Yep. I agree. No
Agree.
argument here.
Yeah, not going to argue what we have scientific backing to demonstrate. That it should be no doubt. It should be a standard.
Yeah, I mean, I think over the since my in my career, the last 30 plus years, the science of physical therapy has grown exponentially. And really most of it is embedded in movement, in all populations. And really that body of literature, that scientific, backing hasn't really, I think, filtered down into the educational programs. We are still teaching things that I learned in PT school, and which really have no diagnostic value. We do it because this is what the book says to do, or and really we really have to re-examine the whole education of the physical therapist. And we cannot change 200, a 250,000 physical therapists practice overnight by changing the name. And I think that it's disappointing, but the change in the culture has to start now. And that's why I brought up the manual therapists. How did they go from nothing to where we are today? In fact, we had to change our Practice Act in California to include manual therapy manipulation. I mean? We had to change the law because we needed to manipulate. And I'm not, look, I'm all for manual therapy. It's a very important part of our practice, but look what they did. Look how they brought along that philosophy and that area of practice and specialty practice so far.
Chris, one of the reasons was when manual therapy got its start, there were no diagnoses. And manual therapists were making diagnoses. They were identifying what was wrong with the joint. And so that they had this thing that raised them above everybody else who did not pretend to understand what the problem was. The doctor said it was this, and then we went on and did whatever. But along comes manual therapy, and they're taking on labeling. So it was a real insightful thing. Plus, you get certified because then you're more than a physical therapist. You've got these special abilities to go with it, and so that you're a cut above.
Well, that's what we need to do the same with movement. I think we need to do the same.
I worked so long, and maybe this was my big mistake, to never certify what we were doing. And the reason was I thought it should be intrinsic in the educational programs and not something that a specialized group had to do. But, I definitely, think I was
Well, maybe movement therapists are going to be a subset of our profession initially until it becomes more mainstream.
Movement therapists wouldn't be good because if you're a actor or you're a Pilates teacher or you're anything, you're a movement therapist.
Movementologist.
A movementologist. Okay. Well, I'm happy with movementologist. So that your suggestion would be we set up subgroups that people meet the certification and then they would be a movement. That's probably what has to happen.
Yeah, and then there
I sent you all some guidelines. I have worked up guidelines for what a movement expert should be, and maybe different people would react to whether it's on target or off target.
I think that's a step we could take.
Okay.
Independent of, I think we need the thought leaders in the movement world.
Isn't that tragic?
Well, look, we've been spinning our wheels, Shirley, for 10 years. And, we want to spin for another 10, we got to do something.
Well, I don't have 10 to spend, so, and
Yes,
I'm just going to make one more point about all this, that this emphasis on being a therapist is another thing why I think pain science has gotten so big. Not that it isn't important, but people think that's a major part of treating somebody and not understanding movement. It's like, I'd rather be a psychologist than a movement expert. I mean, and I think it's always, we're looking for some way to make the patient better instead of I'm looking to understand the problem so that, so that if you have a group I'll give you an example of what I'm talking about. You know, it wasn't that many years ago, if you had breast cancer, you had breast cancer, and there wasn't much to it. Now there are 49 subsets of breast cancer. And that's the only way you get started on greater information, is to put them in a class and then keep breaking it down. And I think that's why it's so important that we come to grips with why aren't people excited about movement causes pathology? I mean, you know, that is so big. Holy mackerel.
What about the other way around, Shirley, where, you know, if pathology can cause abnormal movement as well? So, I mean,
You
you have
got
a
that
stroke
pathokinesiology.
or a,
Helen
you know,
Hislop talked
Parkinson's.
about that.
Yeah.
I'm all for that. And Patty Sheets and the neuro section is doing something about it.
Yeah.
So they are trying to develop diagnosis and directing treatment. And that's why, you know, that's why I think there are two forms, kinesiopathology and pathokinesiology. Why aren't they used and described as the subsets?
Hmm.
Shirley, I agree with you that it's a tragedy that we've not incorporated this into entry level, and you're resigning to the fact that maybe we make it a certification of sorts after entry level. But I tend to agree with Chris. We got to start somewhere, and to incorporate this certification into entry level eventually, like the manual therapists have done. That would hopefully get the attention and improve the accreditation standards that would include the expectation that a graduate would have this.
Okay.
It's important. It's an important step. And then and we need to get out of our way with identifying diagnostic labels.
Absolutely.
I think too, there was a comment earlier about how did the DPT happen so fast and ahead of schedule, right? And now this seems to be stagnating. A lot of it is competition, right? And schools had to change to keep up, to continue to enroll. And I think going with a certificate type process would create that same competitive environment. If everybody's doing it and it's an entry level skill, then everybody should quickly be able to get that certification as part of what they're doing, and CAPTE would logically change the criteria and off we go. But if they're not, then there's incentive for them to figure out how, because the schools that can offer both the PT degree and this certificate in combination in the same amount of time are going to be ahead of the other schools, right? So I think that's a factor that we need to consider too.
Okay. I'll keep working on the criteria. But
Yeah,
you're going to
and
need
I think
input
a
from
lot
other
of, I think,
people. So I hope people will get in touch with me about, I'll be happy to distribute what I put together, and then we can shape it up.
yeah, and I think a lot of programs right now are looking to shorten their time.
Yeah, right. Take out
And
kinesiology and biomechanics.
which means you got to cut stuff out or skim over it rather quickly. And you know, there's some headwinds here, no question about it.
Very good. I'm seeing tons and tons of excellent comments and questions, and
Do we get to look at all of those later?
yes, I will figure out a way to share this rich discussion, not just what you panelists are talking about, but I think lots of excellent ideas and comments here. Barb Norton says many chicken and egg issues have been raised, which is the most important egg to crack first. Training faculty to be movement experts. When Barb speaks, I really want to listen. But yeah, so excellent points. And wow, I could listen to you for discussing for a very long time, but I also want to be respectful of everyone's time. So if it's all right with folks, I mean, maybe there's lots of requests for like, we need more conversations like this, and maybe we need a part two. I'm not sure. Um, but I want to wrap up this town hall meeting with, first of all, my biggest gratitude to these four incredible leaders in our profession. Thank you, Sharon. Thank you, Chris, Paula, and Shirley for being generous with your time. I do think it's very tricky to change culture. But if every one of us is committed, I think something can start up. I think we need both the grassroots level as well as what the APTA can be doing for us. I think it goes both ways. Um, I was recently re-listening to the audiobook called Think Again by Adam Grant. I think it's an excellent book. I thought it would be fitting to finish this session with some quotes from this book, which is basically about letting go of knowledge or slash opinions and to challenge ideas that are maybe no longer serving us as well. And I quote, anchor yourself in flexibility rather than consistency. And another quote, the hallmark of wisdom is when to know you should leave your treasured tools and our most cherished parts of the identity. And so I think rethinking could set us up in the physical therapy profession, or in fact, I know there are other professionals here joining us, any profession for that matter, to become more successful, to grow, to evolve, and to elevate our profession that we care so much about. And what you all showed tonight, not just our amazing panelists, but all of you in the Zoom room right here, is that we all can learn from each other and be the better version of ourselves. And maybe that's how we can start to shift the culture and try to get out of our own way. Um,
So,
this
so
session,
maybe next year we should put together a session for CSM in 2026.
excellent idea.
We should-
Excellent idea.
We should figure out how to do that.
Very good. This was recorded and hopefully, I didn't check the YouTube, but live streaming went okay without a hitch. I will make this recording available to everyone in the Nexus Motion YouTube channel. You probably noticed that when you signed up for the Zoom event, you actually created your free account at Learn Movement System. So when you log in from the website, you will see the lower quarter and upper quarter basics courses. Both of these are provided for you at no cost, courtesy of WashU PT program. So thank you so much for that. Hope you take advantage of the 10 plus hours of learning, and there's no expiration date, so they'll always be there for you. I will email a survey link after this session tomorrow, so you all can give us feedback about what you liked about this town hall meeting, and add any comments and thoughts that you weren't able to put in. Maybe some new ideas will come up later on. We are curious about the prevailing thoughts of the practitioners out there like yourself. So I want to thank you for taking the time, everybody, to come and be with us. I love my profession, and I'm very excited to see where we're headed in the near future. The next event at Learn Movement System is the Foundation Webinar number 1, presented by yours truly. It is currently scheduled for next Wednesday, but due to tremendous stress and setbacks I've had personally experienced in the past couple of weeks, I may have to postpone it by maybe a week. So thank you for giving me the grace. Everybody, please stay. Yeah, please stay safe out there, especially to those of you in Los Angeles. I hope you will consider making donations to your choice of organization to help the thousands of people affected by these historic wildfires. So let's stay in touch, everybody. Thank you so much for your time. And